Thank you, Professor, for being here. We're talking to Professor Ben Rosembaum, professor at University of Copenhagen, Department of Psychology. And here I see that his major interests have been the psychotherapy of persons with psychosis. Okay, so thank you for being here, Professor.
Thank you.
Just, will you just briefly talk to us about your paper tomorrow? Will you be talking tomorrow at the Congress? Just briefly explain to us.
Yes, it will start with explaining a project that we did in Denmark, a comparative project where we compared persons with first episode psychosis who got treatment as usual in the hospital, and another group who got treatment as usual plus psychodynamic psychotherapy. And this was a fair comparison. We had a good 2 years result of this. The persons who got psychotherapy functioned better than the persons who got only the treatment as usual. And at 5 years, as in many other projects, the differences disappear. But still, the persons did better if they have psychotherapy, not statistically better in that sense, with this especially statistical significance that you need to have in order to prove to the world that you are better in one way than the other.
But how better? Which way better?
Well, they had a better function with their peers, with their families, with their social interests, studies, not so much work, but still a little better also in the work.
Okay, I did try and read something about supporting psychodynamic psychotherapy. As you know, I'm not a psychiatrist, so I did try and read something. And one question is, what do you exactly mean by understanding the experiences of people with psychosis? What is the point? What is the meaning, and why?
Yeah. This is a very important question. The psychiatry system, diagnostic system as it is today, is a description of a person seen from outside, from the third person perspective. But the subjective experience of the persons who go through psychosis has been neglected in many different ways. And this has an importance for how we treat the persons. If you only listen for what are the symptoms psychotic or non-psychotic, and then give the person a diagnosis, the person will not feel that he or she is understood by his own history, by the things that he or she has been going through, and by the subjective feelings they have about their life, about their loss of social functioning, about their difficulties when they get into psychotic states of mind, they fear the world. So the subjective experience is very important, seen from a psychodynamic psychotherapy's viewpoint and from the psychoanalytic viewpoint also.
Is it because if you understand the experiences of your patients, you are able to build a sort of empathic relationship with the patient, and this affects the outcomes of your psychotherapy?
Yes, this is one aspect of it. If the person feel understood, feel that he or she is seen and accepted with the strange experiences they have, the extreme experience they have of not feeling themselves in the room, not being able to feel their own emotions, not thinking that they are saying the right thing, all this So this is very valuable for them to meet a psychiatrist, psychotherapist who understand how it is to be in this strange experiential world. And the other thing is that they are seen as a whole person. rather than they are seen as a diagnosis.
Okay. Another thing I wanted to ask you, which I read here in this paper, is that it at times, this approach overlaps with cognitive behavioral therapy, which I know that, just tackle things from a different point of view. It's more conscious, has got to do with more conscious things. Can you just explain how?
If I understand your question right, there has grown a tendency that two approaches, the cognitive behavior approach and the psychodynamic approach, are very different.
Yeah.
This is not so in my experience, and not so in my opinion. I am certainly an integrationist, and I think we cannot help persons with psychosis without being able to have both perspective, and also without we need also to take the frame in psychotherapy, which usually where you sit side by side and opposite each other and talk. That also have to be dissolved. Sometimes you will have to go home to the patient to see how they are in their homes. Sometimes you will have to say to the patient, well, you will need help of a social worker. Psychotherapy is one thing, but you also need to get some work to do. So you will have to be more flexible with your frames, even though you call yourself psychodynamic or call yourself cognitive.
Yeah. Within psychotherapy, which is the role of dream interpretation?
Within psychotherapy with persons with psychosis? Well, I will hesitate a little. I'll try to turn the dream that the person tells me about into the wishes for the future, or the anxiety for his or her own state of mind. It depends what the dream is about. The dream could be a wishful dream. You will help and support the person to say, well, you have perspective on your life. You have wishes for your life. The dream could be an anxiety dream. You will help to understand with the patient that the anxiety, that he or she has to defend him or herself against the anxiety. And maybe the dream tells them how to defend themselves, how they can overcome the anxiety. So you will have to turn the dream into a kind of life narrative that the patient will understand as something that helps him.
Okay. I think that there is a different approach that I've been listening to some papers yesterday and today that just speak of dreams in different terms. And here I've got, Nella that can sort of explain this. What are dreams and how, they are really relevant and important to understand, the patient from a different point of view.
Yesterday we presented some colleagues of mine presented a theory from an Italian psychiatrist, Massimo Fagioli. It's called the human birth theory. I don't know if you ever heard about it.
Yes, I did.
And in his point of view, the dream is a sort of thought for images. It expresses sometimes, as you said, the truth of a person, so an intuition, but sometimes also a negation. He calls it negation. So it's like you deform the reality. So you through the dream interpretation, you can also understand the dynamic of the patient, and you can interpret them. You can help him, because what in his point of view, what makes the patient sick is not just the violence of the relationship by other people, but the reaction that the patient has, the drives, Sometimes he explains this dynamic like a defense mechanism against very, very stressful or very traumatic stimuli, like a sort of interior blackout. He calls this dynamic annulment drive, and this has a disastrous consequence for the patient and for any other. And it can be interpreted by dreams.
Yeah.
What do you think?
I agree with you, and I think I understand the approach also. You see, when a person tells me a dream as a psychotherapist, I have 3, 4, 5 different ways of understanding the dream. So I have to choose which one I will give to the patient. Mm-hmm. And of course, one could be about his way of defending himself against losing his own mind, or defending himself against what he has been experienced. But it's, in my mind, that's a good way. But it also will always have to have a kind of supportive basis of it. It shall support the patient. Not you can make dream interpretation which make the patient's world fall apart.
Seriously psychotic.
Yeah,
you have to wait, even if you understand.
Yes.
Because it's very important that the dream interpretation has to be done just in a therapeutic setting, and it has a transferred. I don't know if we have 2 chapters we translated in English of the first book, that is the knowledge of this Italian author. So
very good.
So we can.
These are the people from Perugia.
No, Rome.
From Rome. Okay.
Yes.
Or the annulment idea.
Annulment,
yeah.
And before moving to the next question, we are talking about dreams and dream interpretation, and how it is important now to understand patient and patient improvement. I think that it is important also to understand whether dream language and images is something universal, and whether you think or can imagine that there is a universal language to interpret dreams.
I think that dream language are images, consist of images. I don't believe in one universal approach to interpret or understand these images. First of all, any image can mean many different things. Like any word can mean many different things. So I don't feel, and I don't think, that there's one approach to understand it. And you can, as a therapist, you can give the dream a meaning that makes it possible for the person to see him or herself in a life perspective. But you can also give the dream a meaning that makes it possible to see what happens between the therapist and the patient. And you can give the dream a meaning to see what happens inside one's own body, as if the experiences of my body in the world. So there are many different ways to approach the dream interpretation.
Nara, what do you think?
Yes, but I think that when the most important approach is the relationship between the patient and the therapist, because it's the only relationship that you are there, and you know the transference reactions of the patient during the psychotherapy and the counter-transference reaction of the therapist while facing with the patient. So
okay, let's move on to the next question. It is DSM. Yesterday we asked Professor Strauss about DSM, and he acknowledged that DSM has got, the big advantage of having given the possibility to make a short diagnosis all over the world, because, up to the DSM, there were psychiatrists in France that could say, okay, this is schizophrenia, and psychiatrists in the United States may be saying, okay, no, this is not schizophrenia. Don't you think that actually the DSM has sort of made physicians lose their capacity of making diagnoses, because it's just a checklist of symptoms?
I think there's no doubt that the DSM and the ICD, the WHO diagnostic system, makes diagnosis more reliable, meaning that we can exchange between us and we know what we are talking about within the diagnostic system. But it doesn't tell us whether the diagnosis is valid, whether it really captures what is the core. If there's a core of psychosis, what is the core? As it is now, the diagnostic system does not describe a core of schizophrenia, a core of psychosis, a core whatever. It describes symptoms. So it's an immense reduction in description, not only of the human being, but also of the ill human being.
Yes. And also, DSM just started to speak of reaction, schizophrenic reaction, then disorder. I mean, don't you think that this is a way of just limiting the issue? I mean, it's just saying disorder. It's not the same thing of speaking of illness. Disorder, does disorder require a cure?
I think there is a great discussion which has to do with to what extent psychiatry is a purely medical specialty. Because in all other medical specialties, you talk about a disease. I would say using disorder makes it, the term is more broad. It gives the possibility for bringing in aspects that were not brought in before. You can always justify the term that you use, but you, in different situations, but you have to justify the implication of using the terms.
Okay.
Implications for that you and I know what we are talking about, the reliability, implications for the treatment, implications for the person who gets the diagnosis, because getting a diagnosis of a mental illness is far more different than getting a diagnosis of a broken leg.
Yeah.
So there are these three elements of it: reliability, the validity also, the implication for treatment, and the implication for the persons who try to understand his own situation.
I see the point, because we were just putting it in a different way. If we don't speak of illness, but we just speak of disorder, then in that case, we are just saying that we cannot speak of cure, because cure is for a disease. It's not, I mean,
Well,
why speaking of a cure for a disorder? And if there is no cure, what's the point of being a psychiatrist?
Again, I think that the medication, brain surgery for psychiatric illness are much more conceived of as cure than psychotherapy is. Psychotherapy is a way of helping the person. It's not necessarily curing the person, but helping the person overcoming different difficulties. So I think that using the term disorder does not mean that we cannot come in as professionals. It's just that it's another way of working with the person.
I see the point. Thank you. Then, what makes the identity of the psychiatrist for you?
It's interesting. I don't think psychiatrists are such a homogeneous group as they want to believe they are.
Then just tell me for you.
Well, my identity as a psychiatrist is combining my psychodynamic, psychoanalytic knowledge with my deeply psychiatric knowledge in understanding what is pathology, even though I know that the patients may not like to be described as pathological.
And what do you think about the human reality of the psychiatrist? Don't you think this is the main point for the psychiatrist identity?
I think that's a very good point. I've thought a long time about it. I think by only sticking to biological psychiatry, which is immensely productive and immensely useful for many patients. By only sticking to that, I think we as doctors avoid teaching other specialties something that we could teach them, which is about how the body and the mind react to these interpersonal relationships that we have as a doctor. We can teach much more to our colleagues, that the mind affects the body, and that makes psychiatry much more important.
So, Professor, where does the mental illness or disorder lie?
Well, I must say, as a psychoanalyst, I've given up thinking of the normal person. The normality consists of being able to reflect on your own strangeness. While if you are in a pathological state of mind, you're not able to reflect upon them. Sure. You are bound by them, you are attacked by them, rather than being able to reflect and have them at a distance, or think about them and change them.
Okay. Professor, just want to conclude our interview with a few questions on suicide, because I know that you run research and studies on suicide. And the first thing I want to ask you is something that, as I said, we discussed with Professor Sadok in Madrid, and then with some Italian psychiatrists in Rome. And I want to gather your point and views on this. Do you think we can really consider a success to extend the time between the suicidal ideation and the actual suicide?
From a common sense view, it is, of course, a help for the patient. That it is, of course, that you think you help your patient if you have a conversation with him. He has his suicidal ideation, thoughts. You talk with him. And when he leaves the room, you can say to him, be sure that he does not go home and commit suicide. If he does not go home, but can come again next week and next week again, that's a postponement. But, so it can be seen as a help, a good sign. But you will have to investigate what goes on in the patient, because I can easily imagine a person who goes home, come again next week and again next week, and the shame grows so much within that he's a bad person. So maybe the extension makes the shame grow. It depends what is happening in the time. It's not only the time in itself, but the events that goes on inside the person and in relationship with the others in that time sequence. That's what counts.
Another point of debate was the sense of guilt. According to Professor Sadok, psychiatrists feel guilty because they've been trained in the wrong way. They've been trained that they can save all patients, which Professor Sadok said it is not possible. It is not possible in medicine, and even less in psychiatry. I told you that this point was discussed during the presentation of a book by Arrietty, by an Italian psychiatrist and professor, Anzilotti. Mm-hmm. And he said, well, actually, the sense of guilt lies in the fact that American psychiatrists in particular have given up research on the human state of mind, on the human research of patients, on the human state of patients. What do you think about this?
I think it's always hard to generalize, first of all. But there's one general observation that has to be done. If you have a patient and the patient commits suicide, it's always hard for you. It makes you reflect. And it should make you reflect. What happened? What happened in the patient? What happened between me and the patient? In the transference, sure. In the interactions? And could I have done anything differently? That reflection should be allowed to yourself. guilt comes up when you do not allow to reflect freely upon that question. When you kind of already beforehand judge yourself, you did something wrong. It was your fault. So this is one thing, and of course it is true that if you think that you never does anything wrong as a doctor, it's a kind of grandiose thinking, a little bit pathological. And it may go for many patients, but it's not a good thing to have that.
Well, actually, Professor Sadok, that physicians feel guilty even if they did whatever they could.
Yeah.
They did their best.
I think part of the guilt feeling is normal in that situation if your patient commits suicide. The problem is not to stay in the guilt feeling forever. I mean, you're working through a mourning process where you kind of internally find out what you did, how you did it, and it could have been different, true. Maybe you could even have saved the person's life, but you did the best you did. And that kind of working through is very important. If you don't do that, you may end up guilty. Maybe you start taking a little of your own drugs. Maybe you start drinking alcohol. Maybe you start not being able to concentrate on the next patients. Maybe you fear having any patients who have suicide ideation in their head. You will not have anything to do with them. Maybe you cannot listen to them. So there are many different ways that the guilt can appear in your future behavior as a doctor.
Do you think there is, or can there be a iatrogenic cause behind suicide of a patient?
Just before this interview went on, I just told you about an incident we had in our project where persons came into the emergency room, was told immediately by a psychiatrist that he had a schizophrenia illness, and he should have medication the rest of his life and he wouldn't be better. And that person was found next day hanging in the tree in the forest. So of course there can be iatrogenic suicide processes also, yeah.
Thank you, Professor. It was really beautiful and nice to talk to you.
Thank you very
Thank
much.
you.
Thank you very much. Thank you very much too.